Okay, looks like we're good to go. It's 2 o'clock, everyone. Welcome to our Wednesday webinar. This is Denise Wilson. I'm going to be your host and present a little bit today. This is our Wednesday webinar for ADAM, the Association for Healthcare Denial and Appeal Management. And today we're going to talk about taking action on winnable denials. Now, this was a conversation that we started in February on our February webinar. If you didn't see that, you can go to our website. You can watch that for free, www.ahdam.org. But you don't have to necessarily watch that to gain insight into the discussion today, because I'm going to go over it just a little bit before we dive into the details and kind of give you a refresher if you came in February, or give you a primer if this is if you did not watch the February webinar yet. So let's get going. Okay, if you're new to GoToWebinar, you should have a participation control panel. If you click on the red arrow at the top, it will allow you to open and close your control panel. You can select whether you want to listen via your computer audio or whether you want to call in. The handouts should be under the handout tab. You go there and you can download them. I know sometimes because it's a pop-up, sometimes your system at your facility might stop you from downloading those. So if you have problems getting those downloaded, just send us an email at info at adam.org. So info@ahdam.org. And we'll get those emailed to you, but it will be after the presentation today. And any questions that you would like to ask myself or Dr. Smith, who's presenting today, you can put in the questions panel, and we will answer as many of those as we can at the end of the webinar. We try to leave, 10, 15 minutes in order to answer the questions for you. Okay, so the CEUs and contact hours, as many of you know, if you've been to our webinars before, we do offer CEUs, but they're for our ADAM members only. So it's a perk of being an ADAM member that you do get a free CEU for attending today. You have to be on this live webinar for at least 50 minutes. So make sure if you're signing in a little bit late that you stay all the way to the end, and then a survey will pop up automatically for you at the end of the webinar. You don't need to do anything. As soon as I end the webinar or as soon as you sign off, the survey will pop up. You need to complete that as well in order to get your CEU. We email the CEU certificates out typically within a week. They're not available for watching the recording of this live webinar. We are recording this and we put them post them on our website usually within about a week. And there are no individuals in a position to control content for this activity that have any relevant financial relationships to declare. Once that survey pops up for you, if you're interested in the CEUs, we offer them from ACTIS, from NARI, from CCMC for case managers. Those are accepted by ACMA as well, AHIMA, and then ANCC for nurses. So you can select as many or all of the CEUs that you're interested in. And like I said, we will send those out, email those out to you in about a week. Okay, our next webinar is going to be on Wednesday, May 18th. At 2 p.m., we're going to do SEAL training, which is the simple effective appeal letter. So we had a lot of requests from our February webinar. I always ask in the survey, what do you want to hear about going forward? And a lot of folks said they just want to know how to structure a successful appeal letter. And I think that maybe speaks to how many folks are still new to denial and appeal management and kind of, want some basics on what do I put in my appeal letter for it to be robust and successful. So we're going to talk about that at our Wednesday, May 18th webinar. That's available for you to sign up now. You can go to our website and register for that today. A little bit about the Association for Healthcare Denial and Appeal Management. We're the nation's only association dedicated to healthcare denial and appeal management. It's our mission to support, promote professionals who work in this field. We want to do that through education and collaboration. And our vision is to help create an even playing field where patients and healthcare providers are successful in persuading medical insurers to make proper payment decisions. Now, the association was successful in being formed because of the financial support that we received from Intersect Healthcare and Appeal Masters. And I want to announce today, you're hearing it here first, that after 16 years of serving healthcare providers under the name of Intersect Healthcare, our sponsor is rebranding as PayerWatch. And so we just want to thank PayerWatch for their continued support of the association and our mission to serve and support denial and appeal specialty and community within healthcare providers. And one of the reasons I wanted to announce that is that we are going to be at a couple of vendor shows coming up soon, not vendor shows, professional organization conferences coming up. We will be there as vendors. We're going to be at the American College of Physician Advisors. That's the National Physician Advisor Conference in a couple weeks in Austin, Texas, and then ACTIS, which will be in Florida at the beginning of May. So make sure you look for the PayerWatch booth, and you can learn more about the association. You can learn about how to join as a member. I think Dr. Smith is going to be at both of those. I'm not able to travel right now, so unfortunately I won't be able to be there to meet you all, but I hope you'll stop by and say hi to Dr. Smith and talk to him about the association. Okay, let me turn my camera on. I just realized I did not have my camera on so you guys can see me. There we go. Okay, so I'm Denise Wilson, and I'm Senior Vice President at Appeal Masters and also President of the association. And I have over 30 years experience in healthcare, so basically my entire adult career has been in healthcare, and the last 17 years in denial and appeal management. And so that's me. And Dr. Smith, who's our main presenter today, who's the Chief Physician Advisor at Appeal Masters. He's also an advisory board member for our association. He's a senior fellow in hospital medicine. He's been deeply involved in denial and appeal management throughout his hospitalist career. He has designed and implemented a number of CDI programs, including those at Cleveland Clinic in Florida and MedStar Washington Hospital Center. And he's a HEMA ICD-10 PCS approved trainer and ambassador. Busy guy. The disclaimer that I need to read before we finish up today: the Association for Healthcare Denial Appeal Management publishes and distributes materials on its website that are created by our members or invited industry subject matter experts for the benefit of our ADA members. We do not certify the accuracy or authority of these materials. They are distributed and presented as research information to be used by our members in conjunction with other research that you deem necessary in the exercise of your independent professional judgment. We claim no liability in relation to reliance on the content of the materials, and the views expressed in the materials are the views of the materials authors and do not necessarily represent the views of ADAM. Any references are provided for informational purposes only and do not constitute endorsement of any sources. And we have no conflicts of interest to declare. Okay, so let's get into our learning objectives for today. Our learning objectives are to identify techniques to focus limited resources toward winnable denials. We talked about that a little bit in February. Describe a process for escalating denials to alternative dispute resolution, and identify methods to evaluate payer behavior in overturning denials using the simple denial scoring tool. Here's our learning objectives for nurses. They just require for the CEUs that we write them in a little bit different way, a little bit more measurable way. So here it is for those of us who are nurses in the audience. Okay, so let's get into the meat of the presentation today. So we talked about this in February. I'm going to go over it a little bit again today, just so that I can refresh your memory, or if you didn't hear about it, you'll get a little introduction to what we're going to talk about today. So I'm talking about appealability, and there is a definition for appealability in legal language, which is being entitled to review in an appellate court. But my definition of appealability that we use in denial appeal management is that an appealability is an expectation of a favorable outcome of an appeal denial based on standards of medical necessity, coding, and clinical documentation integrity. So what is the chance or the expectation or the opportunity to get a favorable outcome of an appeal based on not on the payer's definitions necessarily, or the payer's interpretation, or the payer's thoughts on whether the care was medically necessary or not, but based on standards and medical necessity, standards in coding, and standards in clinical documentation integrity. So why is it important, or why should you think about assigning an appealability score to a denial? Well, it will help you to determine if you are focusing your resources, which I know are very near and dear these days, trying to find enough staff to take care of your denial and appeals is difficult, especially the past 2 years with COVID, and you may not have enough resources to appeal everything that's coming through your door. And should you appeal everything that's coming through your door, sometimes your documentation is going to be not supportive of a code that was placed on the claim, or clinical documentation is not clear, or medical necessity really isn't there for inpatient settings. So if you score your denials, you can begin to kind of funnel the ones that are the ones that have the best opportunity for a win to your resources that may be stretched thin, or may not be available to appeal everything that comes in the door. The other thing about the appealability scoring, and I know Dr. Smith will talk about this a little bit more today as well, is it's a way for you to compare payer to payer. So if you score your cases and say, these are slam dunks, we should get paid regardless of who the payer is. This was definitely medically necessary. It was definitely coded correctly. It was definitely supported for clinical documentation. Every payer that we're contracted or not contracted with should be paying us. And if you're seeing that you're scoring some cases to say this is a slam dunk all day long, and they're not getting overturned on appeal, that gives you a lot of information about what's going on with this particular payer. So that's what we're going to talk about primarily today. So appealability scoring is really a simple scoring tool that you develop to score your denied patient encounters on the strength of that documentation that's going to support that the medically necessary services provided were appropriately billed. Okay, so it's a tool that you develop yourself. You come up with a criteria. You decide how many scores you have, 1 through 4, 1 through 5, or whatever. When you're developing this tool, think about, does the medical record support that the services were medically necessary and were they appropriately billed? And should a reasonable and fair payer reimburse you for those services rendered? So again, it should be payer agnostic, and it should be based on what is reasonable and fair for payment. Okay, the power of using this tool comes from its use as a common denominator. It allows you to compare payer to payer and expose trends in your appeal success, trends in payer behavior, and focus your appeals team on those winnable denials when you don't have the inclination or the staff to appeal everything. And this is just an example, kind of a simple example of an appealability scoring tool. A score 5 would mean this is the best opportunity for overturn. We should win this. It's a slam dunk all day long. A score 4 is a good opportunity for overturn. It could be a little bit better, but there's enough here that we feel it should have been paid. Score 3 is, well, not as strong a case in the supporting documentation as we'd like to see, but it might be worth a shot to try to appeal it. And then the twos and the ones are, no way in heck are we going to get this overturned, or you know what, we were really wrong in billing it the way we did, or coding it the way we did. Those are ones that you're just going to accept your lumps and live with it. We didn't get it right, and we shouldn't appeal it. So as you're developing your appealability scoring tool, this really comes about from your folks who have been doing appeals for a while, whether they're coding, clinical validation, medical necessity. If you ask those nurses and nurse coders and those CDSs, how do they know when they look at a case that they're going to win it or not going to win it? Because if they've been doing it for a while, they have a good sense of, I can win this case, or I'll appeal it, but I know it's not going to get overturned. Take those thoughts and write them down and help understand what constitutes a score 5, a score 4, a score 3, and make it as payer agnostic as you can. Okay, so insights from the appealability scoring tool. What can we learn from the denials that you score a 1 or a 2? Well, there's your opportunity for education process improvement. So you take those 1s and 2s and say, what did we do wrong here, where we know we're not going to be able to win an appeal with the payer, and let's fix that. What about the denials that you score as a 4 or 5? We should get these overturned. We should get paid. It helps you understand which payers are consistently upholding those denials and why. Why? You should be getting paid for those. And those are the cases that you want to focus on to take to external review and alternative dispute resolution. Dr. Smith's going to give us some good stories on success stories on that particular process. So I can't wait to hear what he has to say. Kendall, give me just a second. I'm going to turn this over to you. And okay, there you go. You should have control now.
Okay. Hopefully I do. We'll see. Not showing anything. Denise, in the interest of time, can I pass this back to you and have you advance the slides?
Yeah, sure.
I'm a Mac in a PC world today, and it doesn't like the privacy settings on my computer. So kind of a little IT impaired right now. I've got to get back to being able to see your screen. There we go.
Okay, can you see it now?
Thanks.
Okay, just let me know and I'll
glitch. It's starting to feel like my dad in technology world these days, like with this iPhone. But I'm really happy to see such a great turnout. We have over 300 people listening, and I think this is really indicative of the interest level in this particular subject. For the folks I work with at Appeal Masters and Intersect, we started this project it was before COVID. It was in the year before COVID. Is a way to start to standardize the appeals that we were writing and the information that we were getting from client hospitals that we were handling appeals for. This seems intuitively like a very simple and easy project. As Denise said, you sit down and you talk with appeal professionals long enough, they all get a sixth sense as to what's a 1, what's essentially a appeal that's DOA, dead on appeal, versus a 5, which is something you just keep running to the mailbox every day looking for the check. And the interesting thing, I'll kind of come to the end and then start in the beginning, is having worked with this for 3 or 4 years, I have to say that something as simple as a 5-point scale for an appeal system is a deceptively simple project. And the information that comes out of this system, I think from the standpoint of improving quality, both of documentation in the charts, as well as quality of care being provided to patients, is probably the most powerful tool in a healthcare system. And I've thought about this for a while, and I think the reason is finally percolated through to me, which is you're sitting with a denial, which means that somewhere something hasn't clicked as it should, whether it's an insurer, whether it's a process issue, whether it's physician documentation, whether it's a CDI query that wasn't done correctly. And that denial, then essentially each denial becomes a mini root cause analysis as to what's going on. And through this, we're able to capture payer-specific information, find out how our payers are doing, but we're also able to identify hospital processes that need to be worked on or tuned so that you don't get a second, third, or fourth denial. And before this system existed, we were doing a lot of that and making recommendations, but it was based on a gut check. It was really hard to get good objective data. We could certainly look by payer and see who was denying things, but it became very difficult to say were those denials reasonable under the circumstances. You know, it's one thing to say that United Healthcare is excessively denying sepsis cases. It's another thing to say, well, United has a policy about how sepsis should be coded and the hospital is not compliant with it. And when we go back and look at the hospital documentation, we find out that it doesn't meet what United Healthcare's expectations are. So we're sitting with a medical record, which is an entirety of an episode of care. And the denial says that something is kicked out here. And auditors looked at it. You know, it may have been a computer that did it, an AI program. It may have been a human. For some reason, they've kicked that claim out. And you have the entirety of a single episode of care at your fingertips. And now, as an appeals professional, you're looking at this and you're making a determination about what happened here, what was wrong, what could be done better, or what was done right, and what should the hospital do to get paid. Deceptively easy project, and the data that comes out of this and some of the processes that ensue from this are incredibly complex and touch on virtually every department within a healthcare system or hospital. You want to go to the next slide, Denise?
Mm-hmm.
So one of the things I would caution you about is you can certainly walk out of this talk today and say, we're just going to, as a department or as a group, start rating all of our appeals on a 1 to 5 scale and come up with a scale as to how to do that. What constitutes a 1, what constitutes a 5, and we're going to score all these things going forward. I would caution you, though, that this data, you need to make a decision up front about what this data is going to, what's going to happen with this data, what kind of life it's going to have, how are you going to deal with these things when you start to see that insurer B is routinely upholding cases that should be paid, or that you have an issue where physician A documentation isn't appropriate to the diagnoses that they're putting on the chart, that they need some education about documenting sepsis or encephalopathy, for example. And so you got to make a decision as a department within the hospital or as a group of professionals in the hospital is to where this information is going to go, who's going to get it, and how you're going to corroborate with people. And I think as you see some of these processes unfold, what you're going to realize is that appeals management is probably in a position to become one of the most powerful and useful departments within a healthcare system by virtue of having this data and being able to feed back information throughout the organization to drive improvement. The other thing that I think you may walk away from this talk with is a realization that as you drive this improvement, as you start to fix things and you take care of the easy fixes, that your work in the denials world may actually get more complicated because you've taken the low-hanging fruit and you've gone and fixed that and driven significant economic impact to the hospital. But as a result, the denials that are now coming to you are increasingly technical, You fix things that are the easy fixes, and your arguments and the appeals that you're going to get are going to be a little bit more difficult. You may actually make yourself a little bit more work through doing this, but it's necessary, and I think it's valuable. It's much like the early stages of the CDI industry, when we had CDI professionals working with physicians to improve documentation, and looking at the gains that the CDI was able to make in revenue and quality indexes for a hospital. I think we're going to see the same impact with that we do with the appeal professionals as we did with CDI early on. So a decision has to be made up front as to who's going to get this data, what you're going to do with it, how you're going to report it, who it's going to go to, and who's going to be responsible for it, because it does become very powerful, and like anything that's powerful, it should be managed. Go on, Denise. So what we've learned throughout this, and we're talking thousands and thousands of appeals that have gone through the scoring system, is that in essence, these appeal scores can serve as a call to action. A 1 to me, an appeal that scored a 1 or a 2, like 0 chance of overturn or little chance of overturn, as Denise said, sort of a dream chance of being overturned. The information from that is just as valuable, if not more valuable, than something that should be scored a 4 or a 5 and not paid by an insurer. So when you're looking at a group of things scored a 4 or 5s that aren't paid by an insurer, you've got a problem with your contract, or you've got a problem with insurance or medical director that should be dealt with externally. Generally, when we're looking at 1s and 2s, as you're going to see, you're dealing with hospital process issues that need to be fixed internally. It's much like your check engine light. It tells you as a driver, you need to get to a mechanic and get someone to take a look under the hood. It doesn't necessarily tell you where to look. And that's what I think these things are really good at doing, is drawing attention to various departments within the hospital, contracting, managed care, for example. You may find that you have some issues with coding, as Denise mentioned. A 1 or a 2 may reflect a diagnosis that was coded that there's no documentation on the chart to support. We see those. Human beings are involved in this, and everybody makes mistakes. What you're looking for are mistakes that become patterns. So you may find out as you track back and start to look at those 1s and 2s related to coding, that there's a specific coder that may not be aware of coding a specific diagnosis. And you're going to start to see these things pop up over time. You may see things like registration where you have no auths. And you may find out as you start to look at the 1s and 2s related to no authorization, that actually is just occurring on Saturdays and Sundays. So what these things allow you to do is really get some cases together, and then start to drill down into those cases and say, okay, what's the root cause, or what do all these 1s and 2s have in common? Why were they occurring, and what can be done to fix it? You don't necessarily want to just start scoring things and realizing that you've got all of this power behind this and not be able to take it to the next step. As I mentioned, you may find that there's physicians involved that need education or some discussion about documentation for specific diagnoses. They may need to be made aware of payer policy guidelines, which says this particular insurer is only going to pay for this treatment if the doctor does A, B, C, or D, and they may not even be aware of those things. So the ability to get this information back to the front end or over to managed care and contracting to deal with the back end or after the hospital discharge with the insurance companies is critical. And I think that's the one thing this really does well is sort information for you at a high level. You want to go on, Denise? So, ask yourself up front, where in your organization is this data going to go? Who do I have as an ally, or who might have an interest in hearing about this? It may be a director of the revenue cycle. It may be someone that's over CDI. It may be the director of UR. It may be your chief medical officer. It could be any number of people in your organization. Org chart for every organization is obviously going to look different, and the people that are going to be interested in this information are actually going to differ hospital by hospital. So I won't go through and say that this is the best department to deal with these types of 1s and 2s, and this is the best department to deal with these types of 4s and 5s. You know who those folks are in your organization, and start to draw those org charts out for yourself and figure out who's going to have a vested interest in hearing about this. Go on. So my personal best practice is after a couple of years of doing this in several thousand cases, and keep in mind that we write for a really significant number of hospitals and healthcare systems across this country. So I'm interacting with a lot of different physician advisors, chief medical officers, directors of UR and revenue. Is that you need to establish relationships with different hospital departments to best utilize appealability scores. You can put the scoring system in place tomorrow, but you should start to develop those relationships over the coming months as you start to accumulate this data, so that after you have 3 or 6 months of data, you've got some folks that you can go to and talk with. They may be a director of the revenue cycle or the revenue cycle committee. It may be a physician advisor in the UR department or a physician advisor working with you in the appeals department, someone in contracting, hospital's attorney. There are any number of folks that you're going to want to network with and start to discuss this project and explain to them what it is you're doing and what the potential implications are. I quite often am surprised in dealing with chief medical officers and physician advisors for systems when they come at them with this data. They've never really even stopped to consider its potential impact and the value that's in it. You want to, next slide, Denise? So one last thought, and this, as a physician, you're always used to folks looking, as an employed physician, looking at your productivity and making sure that you're pulling your weight. And it's difficult, I think, in the appeals department, and you are to quantify the dollars that you're bringing in. You can certainly look at the overturned revenue that you bring back to the organization, and that can be significant. We're talking, if you're able to fix $1 million denial and pick that up here, say it was a 5, and we'll show you some examples of this, that didn't get paid, that's $1 million in direct revenue you're going to bring to the bottom line for the system that wasn't otherwise going to be there. And it takes a lot of work for a system to generate $1 million in net revenue. But as you get better and better and start to fix these things, you start to develop a relationship either directly or by proxy with a insurance company medical director, or you're able to fix things on the front end with registration, you're going to find that the types of denials you're dealing with become much truer areas of disagreement, where there aren't these cut and dry fixes. And you may find that your overturn success ultimately starts to drop. Kind of the paradox of doing things better is that if your department's just being tracked on dollars overturned as a success metric, you may find that 6 months or a year from now, if you've been able to engage and fix some of these things, that your appeals are getting harder and your overturn rates are dropping. And to me, that's sort of the paradox of this, or evidence that you're being successful in doing what you should do. But you really need to have some discussion up front, much like a CDI department does, about what the value is and what the baseline is for the hospital, and then the value you're able to impart on an ongoing basis by fixing these things. So if you're able to fix some things and point out issues with registration or payer X that's been ongoing for several years, and suddenly that ceases to become a problem, there should be some discussion up front to make sure that your department gets credit for those things on a year-to-year basis, because hospitals, in my experience, are often quick to forget what the old world was like. And it's difficult to point to that 2 years down the road and say, I did that, our department did that, and we want to make sure we get productivity credit for it as a group. So it's just a sort of takeaway message at the beginning of the discussion. Next slide, Denise. So some examples of what we found in looking at this. Go ahead.
Go ahead. I'm sorry.
Oh, no, go
I
ahead.
was reading.
Yeah. So these are success stories, and some of these things really, really surprised me because, for example, we looked at a large West Coast health system we partner with, and I started to look at their cases that were rated as a 5. Found 3 cases worth $1.5 million that had been upheld by the insurer, and the letter came back and said final appeal level, no further appeals available, and the system had closed out. In these particular cases, we were able to engage with the system medical director, who then reached out to the insurance medical director and get these cases overturned. We'll show you an example of what one of these cases looked like and why you would not have been able to focus on this particular issue unless you had graded the case. Without these cases being tagged to 5 for that particular hospital, those 3 cases would have probably gotten lost in the noise because they had several other large dollar denials that were rated 1s and 2s. So where do you spend your time? As Denise mentioned at the beginning of the talk, this 5 system, these cases that had been scored as a 5 became an immediate area of focus to say, wait, we said these should be overturned. They weren't. These are really high dollar cases. Let me take a look at this whole thing beginning to end, see what's going on here. And the moment you crack these things open, 2 things became true. Number one, the insurance company was clearly wrong and had made some mistakes, whether deliberate or not, it's my own issues. Number 2 was, despite having a large number of folks writing these types of appeals, a 5 was a 5 was a 5. As Denise mentioned at the beginning of talk, it was really refreshing to see that the inter-rater reliability, and this slide aside, I would hazard for us has been over 95%. So probably 9 times out of 10 or 95 times out of 100, I look at these, I'm going to agree with how the writer graded them. In the cases where I've disagreed, they may have called it a 4. I would call it a 5. I'm a little more bullheaded, so I'm intended to think that we're entitled to get paid. Where someone may have just said, this was like a 5 minus, I'm going to call it a 4. So there hasn't been any real disconnect where I've seen somebody rate something a 5 or a 1, and someone else call it a 1. This is generally pretty powerful, and the fact that the appeal writers were looking at these things and consistently calling a 5 was really refreshing, and it was good to see because it upheld a lot of things that I felt to be true. One of the interesting experiences we had earlier this year was a hospital in the Mid-Atlantic. We looked at 23 Medicaid cases that we'd rated as a 3, 4, or 5. So these were the kind of neutral opportunity through absolutely should have been overturned. Commercial Medicaid cases, all of these have been upheld by an insurer, and under the insurer's contract, there were no further levels of appeal available. We bundled all the 3, 4s, and 5s, sent them for external review. The cost was $675 per case. The hospital paid if they lost. The insurer paid if this was overturned by an external independent reviewer. So it's a good chunk of change. It's almost $15,000 to see what happened with these things. But we saw, surprisingly, even when we threw the 3s in there, that there was an 84% overturn rate with external review. I'll tell you, majority of the cases were 4 or 5, so there were very few 3s in there, but there were a couple of 3s, and even an independent reviewer, when we graded them a 3, surprisingly overturned. So it certainly says that your 4s or 5s are really cases that if you're getting back a case that's one of your appeal professionals has graded a 4 or 5 and you're not getting a check back with it, those are cases that someone should be looking at and figuring out what can be done with these, because they probably haven't been adjudicated correctly. And I'll show you some examples of these, and it's not going to surprise you, I think, when I show you the examples. We've all seen these instances, but it really does drive home the need to do this. Go on. And this echoes back to what I said at the beginning of the slide, which was if you set this system up in a vacuum, you may be knocking on doors for a while trying to get attention. So I looked at another hospital system that had almost $23 million in upheld cases that had been closed out. by the system, and we had graded them as a 4 or a 5. And I said, wait a minute, we need to take this experience of this mid-Atlantic hospital, of our East Coast or our West Coast hospital, and we really should get the system to look at these, take them to their joint operating meetings, have their legal department take a look at these. There's something going on here, and this is a lot of money. I mean, this is charges, but even at 60 cents on the dollar, you're dealing with about $13-14 million in potential revenue. I have emailed and called till I'm blue in the face. I can't get anybody to return a call because the system isn't set up to deal with this idea of, wait, we really need to do something about these things. The insurers aren't always acting fairly. So back to the earlier conversation of get your ducks in a row up front. So when you do get numbers like this, when you do get a huge group of 4s or 5s, or a couple, even three or four $500,000, $1 million cases that were graded a 5, you've got an ally within the system to be able to carry these things forward. The appeals professionals probably aren't in the best place to do this, as we'll show you why, but these are things that need to be escalated. They need to be a chief medical officer, a chief physician advisor to a medical director at the insurance company call. They're going to need to go to external review for the state. They may need to go to the State Department of Insurance, but those are decisions that are probably beyond our everyday scope of work. Next slide. So what do these cases look like? And I'm going to show you 2 case studies, a 5 and a 1. And this will give you an idea as to what each end of the spectrum looks like. What do we call a 1? What do we call a 5? But I think you'll intuitively realize that for the cases that we scored a 5, that obviously the insurer's opinion was wrong. And even though they said there was no further level of appeal, that something should be done to get the money that was rightfully owed to the hospital. And in the case that we're going to show you that was a 1, that clearly the insurer was probably within its bounds of not paying the claim, and the error in the fix resided within the healthcare system. And by being able to fix that issue within the healthcare system, you could see how you would prevent additional denials down the road. Hence the value in the work that you're doing on the 1s. The 1s are just as valuable as being able to fix as being able to go out and get $1 million 5 paid that the insurers wrongfully upheld. I think actually there's more value probably in fixing the 1s and 2s because they're going to continue to occur than in getting a single 5, but you don't want to let any of that revenue go down the drain. It's too much. So do you want to go forward? One of the key truths, and I think we've talked about this in earlier webinars, is that the insurer's narrative about a denial may not always accurately reflect the issues or the facts at hand. And so proceed with caution when you get a denial letter about taking on the insurer's version of events. They may not have had all the facts at hand. They may have been wrong. They may be completely out in a different part of left field when they send you a letter. But if you start your narrative back to them by engaging with the insurer's version of events and not verifying facts before you write a letter, and we'll probably discuss this in the upcoming SEAL webinar, is you're gonna get yourself into a world of hurt. So a good thing is always take a step back, be objective, and say, should this case have been paid? So in this case, they say that they were denying this because there was late notification or no notification. Okay, so intuitively, they're saying this insurer is presumably contracted with the hospital. We didn't authorize them. That's probably grounds to not pay. But let's go a little bit further because things aren't always what they seem. Next case. So this was the response to the appeal. So we sent a letter in, which I'm going to show you. The insurer considered the letter and then came back and said, yeah, we're still not going to pay the claim. We're upholding our original decision, which was no auth or late auth. Go on. So this was a 13-day length of stay. Was scored as a 5, $500,000 in charges. So, it's a pretty significant bill. You want to go on? And this came out of the denial, as Denise will show you next month with the SEAL training. This is how we kind of recommend putting information forward to get it in front of the reviewer's face. But something immediately leapt off the page at me. When you look under procedures, you see CPR as a procedure. So I don't really have to go much further into this denial to say this was, the most severe of all medical emergencies ever, because most hospitalizations don't have CPR listed as a procedure. And there was probably a good reason the insurance company didn't get the auth. Either the hospital got it or the insurer lost it. But clearly you should get paid for performing life-saving or life-saving procedures for patients. And if you're providing emergency care, you can't necessarily run out and seek an auth, which we'll see here in a second. Go on, Denise. So here's the brief narrative about this patient. The patient was started on a heparin drip in the ER and then went into a VFib arrest due to an acute MI and had CPR, sent directly from the ER to the cath lab for an anterior wall MI, and then admitted to the ICU, presumably intubated. At the bottom, it says intubated on 100% oxygen, encephalopathic. So where along this procedure would a registration department stop the patient and say, I need your wallets or I need to see your insurance? Probably nowhere. It'd be a violation of Entella, but it would just be absurd to even assume that they would be able to provide a timely notification to the insurer for this case. Actually, what actually happened, go on, was the UR department did, in this chaos, submit an inpatient notice through the portal. They got a reference number back, and that was included with the appeal. Excuse me. Go on to the next page. So we went back through this case. I went back through the data for this hospital, and we found 187 claims where this particular insurer had upheld their original denial. Almost 200 of these we graded a 4 or 5. There were $6 million in closed upheld cases that were 4 or 5. Many of them had facts at hand similar to the case I just showed you. We bundled all those up and took them to the managed care department. Said you need to get a joint operating meeting together with this payer and get them to pay you for these things, because I don't need to look at all these cases individually. I looked at one to know that I'm confident in the 4 or 5s, and that when I went back and I sorted the information by payer, so we've got the score, the 4 or the 5, and we know who the insurer was. Do a quick sort in Excel. Magically, I've got 200 cases worth $6 million for this particular insurer that we believe should have been overturned. Someone needs to bundle all this up and sit down and have a discussion, and that's where this sits right now. Go ahead, Denise. Excuse me. So what does a score of 1 look like? This was the letter that came back for the insurer. An elderly patient came in with dementia, bradycardia, failure to thrive, and not eating, no oral intake. They were hemodynamically stable on room air. Their labs were pretty much normal, and they got admitted for a G-tube placement. Not real exciting compelling as far as needing inpatient care. And as we'll show you, this got a score of 1 because there was really nothing acute going on with this. The patient was chronically deteriorating and came in essentially for an elective G-tube placement. Next screen. One of the things that always helps with these is we recommend putting a peer note or a performance improvement note in, especially with the 1s and 2s, as to what could be done differently. In this case, the reviewer put in a note about observation order and then inpatient order. The patient was put in inpatient and then observation. And there's some confusion as to what status the patient was in. But you've got that case in front of you. Why not put a 2 or 3 sentence excerpt in there as to what went wrong? So when someone comes back to analyze it, you can start to look and say, where did this go out? Was this a UR problem? Was this a problem specific to this particular physician that may need some education about inpatient and observation? You may sort the ones and twos and find out that you've got 20 for an individual physician. And when you start to look at the root cause notes, you may see inpatient observation order confusion for that doctor that you could go back and talk about. So a performance improvement recommendation in this case is simply take the case. You're not going to get paid for inpatient. The orders are all over the place. It's not really clear. The patient had no acute problem. Let's just bill it for observation and then try one day as inpatient and get paid that way. So these performance notes always help, especially at the left end of the spectrum. Go ahead. So some takeaways from this, and this has been a fairly short talk, but I hope you get the feeling that you understand both the power and complexity of the scoring system, is that you're really in the ultimate position to sit in armchair quarterback an episode of care. You've got the entirety of a course of care from the ER through admission through discharge sitting in front of you. And you also are the only one in a position to keep the insurers honest, to look at that episode of care, read the insurance denial, and decide if they line up, or whether there's something going on with a particular insurance company where they're targeting things perhaps unfairly. Certainly a best practice is to sit down with your department if you're going to do this and talk about how you're going to use the scoring system going forward before implementing it. Getting some champions in the hospital, physician advisors, chief medical officer, someone in registration or you are on board with it is great, because you're going to want to take this information and have somebody take care of it for you. I can tell you, looking at a pile of fives worth several $1 million, you start to get really worked up because these things should have been paid. And the fact the hospital didn't get $2 or $3 or $4 million becomes a really strong incentive for you to do something. It can also become very frustrating if you can't get a hold of anybody to take action on it. Likewise, a 1 or a 2 where you're seeing a recurring problem, you can come up with a quick recommended fix or solution to it, an educational moment or something else, and you can see the dollar value of these things because you've got them all in your scoring system. You can see all the related 1s and 2s. But if you don't have someone involved that you can take them to and say, okay, if someone from UR or a physician advisor, you can take these two and say, here's the common denominator amongst all these things. This is what we'd recommend to fix it. You're likewise going to get a little bit frustrated because you're going to see ongoing denials related to that issue, and you're going to realize, I don't have anybody listening to me. So conversations and some discussion about the powers of what you're seeing, I think are imperative to this. And then the ability to demonstrate the value of the work that you're doing that comes from this is likewise important. So identify key players, know where you're going to take this information. As I said, there's nothing wrong with starting to score these tomorrow. It may take you 30, 60, 90 days, even 6 months to get enough cases into different columns to sit down and look at them. But also have some good data hygiene, have some discipline, and be able to, every 90 days, challenge yourself to go back, pull your 5s, pull your 1s, go back and look through these at either extreme, and decide what you're going to do with them. Or you're going to escalate them, because you may have limited options in terms of timing and getting these things paid. But know what you're going to do with these so that on a regular basis you're looking through them, knowing what your next steps can be, and make sure that the system you work with is okay escalating these to the State Department of Insurance, where you can't get where the insurer hasn't paid the 5s that should be paid, or external review. You can see that you need to get someone on board with the $400, $500, $600 charge for doing that. But if you got a 5 and you're seeing that there's a really good chance that that particular case is going to be overturned on external review, then it really it becomes fairly easy to convince people to let these things go forward. And you really should make sure that you're pushing these forward, or you're sending them back to managed care for a joint operating meeting to sit with your insurer and say these need to be paid. You're a little bit not quite right here with your reasoning in denying this, and we want to challenge you on it. I think that's the last slide, Denise.
Yeah.
So it
very
was
good.
Oh yeah. So last point, and we've seen this, is not quite the last slide, is the last two takeaways is you may find the payers start to move the cheese, and we've seen this with different insurers, where they've started to by policy guidelines start to move the cheese, so that you may get, let's say, insurer A puts in a requirement for doing Botox for migraines, and then all of a sudden you make sure the neurologists are doing these, are aware of those guidelines, and they're following them. A year later, 6 months later, you start to see an uptick in denials for that procedure, and you're rating them a 1 again. You may find out that you go back and you look at the payer policy bulletin, they got updated and changed. So just around the time you're getting everybody on board, you may find that the payers move the cheese on you, and you're starting to see an uptick in these. So keeping a good eye on your data will tell you if there's been payer behavior change that you need to be aware of. And then, as I said, you may be dealt with some, have to deal with some evaporating gains as you're successful. Your denials may actually become more challenging to overturn as you start to prevail with some of these. And that would be my final takeaways from it. As I said, it's something I'm really passionate about, obviously. I think it's incredibly powerful. I've never, in 20 years of working with UR, I've never seen a tool that was this simple. You're already, and quick. You're already in the chart and the record looking at it. You're looking at the insurer's opinion of the care. And something that was this powerful, quick, to be able to deliver process improvements across an organization. It's incredibly motivating. And for me, the joy in it has been to remove some of the headbanging frustration that I felt in dealing with appeals, where I'd see things over and over, or if I was seeing insurers that weren't paying things, starting to get them paid. So in terms of satisfaction for those folks that are appeals professionals, it's been incredibly powerful and motivating for me personally. So I can't say enough about it. You know, it's free. There's nothing trademarked or proprietary or copyrighted about a 1 through 5 system for anything. It seems incredibly intuitive and obvious, but I can tell you at the end of the day, it's so empowering that I would really encourage you to get behind this. And I think it'll become an industry best practice as we move forward.
Right. And it does not have to be complicated. Don't overcomplicate it. Keep it simple. Your appeal writers will learn the 1 through 5 quickly, because they're already thinking it in their head. They already know, it's a 5. So it's not something that every day as they write an appeal, they've got to look at their scorecard and say, oh, is this a 5? Is this a 4? I mean, they get it really fast. So, so I hope you all will use it.
It's seconds of work for folks that are in the record already. As Denise said, people that are writing these, once you write 5 or 10 appeals, your brain's ability to slice something on a 5-point scale of absolutely we should have a check in the mail tomorrow to there's no Sam Hill way that we're ever going to get paid for this is pretty intuitive. And in fact, we work with a really large number of appeal professionals, of writers, and we've seen reliability across this over time supports just that my 5, Denise's 5, anyone else's 5 is going to be a 5 at the end of the day, and the 1s are going to be a 1. You may have a little bit of disagreement of the 3s, 4s, or 2s, but even at the end of the day, there's a really high concurrence rate with it. And as Denise mentioned, you're not obligated to using a real complex metric. A simple 5-point scale is really simple, quick, powerful, and it's free.
Okay, I've got a couple of great questions that came in for you, Kendall, so let's get to those. I want to thank our support team at the corporate office, as I always do. They're quite a crew. And we want to say happy heavenly birthday to our good friend and colleague, Mr. Mark McGraw, who left us, went ahead before us. And so happy birthday, Mark. And let's do the Q&A. Kendall, a couple of good questions came in. How can hospital medical directors establish a working relationship with the payer medical director when the payer does not offer peer-to-peer options for discussing denials?
Those contacts have often had to go through the managed care contracting department. I've looked, you may end up networking with them on LinkedIn. I've been known to stalk folks on LinkedIn when I've wanted to get to know them from the payer side. So get creative. It's quite often when you want to meet anybody professionally, how do you go about doing it? Find a common point of interest, or a common contact. They said that the Rolodex that the managed care contracting office has is generally a good place to start. LinkedIn's another great place to start if the hospital will allow peer-to-peer. Funny story, I did contact a insurance medical director at a large national plan and worked with her to overturn 2 5s that were 6 figures each. And when I called back with the third one, she was no longer available to take my call. So it was kind of got disappeared. So it was an interesting experience. So those professional contacts, especially where they're amicable and agreeable, may be short-lived. No plan on knowing that patient, that doctor 10 years from now.
Okay, and we're right up at the top of the hour. There's a couple more questions that came in. I will make sure that we answer those either individually or we'll put them up with the recording of the webinar. If you do have questions, I'll leave this up and running for a little bit longer if you want to enter additional questions that you may have, or you can just email us directly, Denise@adam.org or ksmith@intersecthealthcare.com. Thanks, everybody, for attending. Thanks, Dr. Smith. That was really great. I just love hearing those success stories, and I hope you all will consider taking this methodology and working with it and see how it works for you. So we'll see you all in May. Have a great spring, and we'll talk about the simple, effective appeal letter when we see you in May. So thanks, everyone.
Thank you. Yeah.